Recognized for his contributions to musculoskeletal ultrasound, regenerative medicine, and interventional pain management. We welcome you, Professor.
Good morning, my dear colleagues. It's my privilege to follow Dr. Moni for my talk. My talk today is ultrasound image and the guided injection for the hip joint. So if we want to master the scanning of the hip, the bony landmark is very important. There are several bony landmarks that you have to bear in mind. For example, the anterior superior iliac spine, anterior inferior iliac spine, and then femoral head and the femoral neck. So besides the bony structure, there are also some ligamentous structure that you have to remember during the scanning of the hip joint. For example, the one that connects the acetabulum and the femoral head, that one is the iliofemoral ligament. And another is the tendon that attached to the laser trochanter, that one is the iliopsoas tendon. So after you understand the bony anatomy as well as the ligaments that are important over the hip region, another one is the muscle, because the muscle can help us to navigate the hip joint. So what are the muscles that we have to know if we want to master the scanning of the hip region? The first one is the sartorius. As you can see, sartorius emerges from the anterior superior iliac spine, and another one is the tensor fascia lata. So both muscles attached to the anterior superior iliac spine. And then another one emerged from the anterior inferior iliac spine. That one is the rectus femoris. So more medially, you are going to see another muscle, which is the iliopsoas. So iliopsoas is made of two muscles. One is iliacus, the other is psoas. And then more medially, you are going to see another one, which is the pectineus. Pectineus emerged from the pubic ring and attached on the laser trochanter like the psoas tendon. So this is the zonal anatomy of the hip joint. But remember, if you want to scan the hip joint, the orientation of the transducer is very important. As you can see, I'm not placing my transducer in the surgical plane. Instead, I let the medial end over the cranial end of the transducer point to the umbilicus. And this is the perfect alignment for the hip joint. And so on the ultrasound image, you can see this is the iliacus muscle, this is the sartorius, this is the rectus femoris, and on top of it, you are going to see the psoas tendon, as well as the iliofemoral ligament and the anterior hip recess. And do not forget there is a labrum, triangular fibrocartilage extending from the acetabulum. So this is the point that we usually place our needle over here for the hip joint injection. So remember, if you want to proceed the hip injection, you have to understand that there are some vessels crossing over this area. The vessels is so-called the lateral circumflex femoral artery. So this is where the artery is located. So if you want to see the artery, you can turn on the Doppler, and then you can see this is the cross-section of the femoral artery. And then if you want to do the hip joint injection, usually you have to turn on the Doppler to find out where the vessel is. And then when you insert your needle, you are going to prevent from hitting this artery. And the location for ducting our needle is usually between the femoral head and the femoral neck, because here this is the contour of the anterior hip recess. So if you can let your needle position over here, theoretically when you push the injector is gonna flow back to the joint. So this is how we perform the hip joint injection. In this case, you are going to find that the hip recess is dilated. So there was some effusion inside it, and this is where the lateral femoral circumflex artery is located. So we insert from caudal to cranium, And then once our needle get into the hip recess, we can start to push the injector. So there are some pathologies that can cause pain, just like patients with hip osteoarthritis. For example, in this case, we are going to find that there is a thickening of the attachment of the direct head of the rectus femoris, and inside the tendon you are going to see a hyperechoic plate. And then you can compare with the other side the fibrous plate. And then this is how we can perform the rectus femoris direct tendon injection. So here this is the location of the direct tendon, and then we use the axial plane to target the direct tendon for injection. So in patients with anterior hip pain, we know the most common pathology is the patients with hip osteoarthritis. But in some cases, if you have ultrasound image like this is where the iliopsoas bursa is located. So in this case, you are going to see there is calcification inside the bursa. So if you encounter a patient like this, you can consider to perform iliopsoas bursa injection. So another case, you are going to find that in the patients with hip pain, you are going to find that there is an echo-Int fluid accumulation over here. The patient has a parallelogram cyst, so the patient is going to have pain, just like those with hip osteoarthritis. What we can do is we can do ultrasound guided aspiration to aspirate the fluid inside it. After the fluid is aspirated, sometimes we can add some PRP or some regenerative regimen to improve the healing of this region. So this is the image of the iliopsoas bursitis. What I want to highlight is in patients with diffusion like this, in the beginning, you may thought the patient only have bursitis, but in reality, in many cases, the iliopsoas bursa has a connection with the hip joint. So when the bursa is dilated, actually it's from the increased intra-articular fluid. So the fluid is gonna emerge from the articular space and it goes all the way to the bursa to let it dilated. So this is our case collected more than 10 years ago. As you can see, the patient has lots of diffusion inside the bursa. So for this case, we perform aspiration and the steroid injection for many times. But unfortunately, even we perform so repeated injection for this patient, the patient still have pain, and then the fluid keep emerge from the bursa. So that's why later we perform MRI for this case. As you can see, the femoral head had been fragmented. So the patient has a vascular necrosis of the hip. So that's why if you encounter a case, you perform the iliopsoas bursa aspiration and the patient did not respond to your treatment well, you have to consider the possibility of the intra-articular pathology. So another thing is this is the case young 18 years old, young athlete. As you can see, the patient complains of pain over the anterior medial aspects of the hip. So on the ultrasound, we find at the insertion of the source tendon, you are going to find that there is a hyperechoic plate in comparison with the normal side. So if you use long axis, you are going to find at the laser trochanter, there is a bony plate that is detached from the laser trochanter. So the case has an epiphyseal injury. It's very common on young adults, especially the young adults are physically active because their bony epiphysis is not mature, so they are vulnerable to have an epiphyseal injury. So this is another case, with patients with anterior hip pain, they might have the possibility of the snaking hip. So if you put your hand over the anterior hip, you are going to identify or feel the abrupt movement of tendon underneath. So in patients with snapping anterior snapping hip or internal snapping hip like this, the problem is usually between the psoas tendon as well as the adjacent iliacus muscle. So of course the ultrasound offers the benefits of dynamic scanning. So we can see what is the pathophysiology for these cases. And then we can use the axial view to scan this region. And then of course we can use the long axis view. In the long axis view, we can still see similar findings. So for this case, what we do is to dilate the space between the psoas tendon and the medial iliacs muscle. So once the space is enlarged, it allows the tendon to move more freely. So once the tendon becomes more movable, the snapping would thus decrease. So let's transit to the lateral hip. So regarding the lateral hip, there are several muscles that we have to remember. So the muscles include the gluteus minimus, gluteus medius, and the gluteus maximus. And another one which is located at the anterior part is the tensor fasciae lata. So the gluteus minimus and the gluteus medius, those muscles are gonna insert on the greater trochanter. So this is the bony anatomy of the greater trochanter. So at the anterior aspect, we are going to see the very prominent anterior facet. And then at the lateral side, you are going to find this is the lateral facet, but the attachment for the muscle, gluteus medius, is only at the posterior aspect of the greater trochanter. And the anterior, at the anterior aspect of greater trochanter, we are going to call it bare zone, because in bare zone there's no tendon fiber attaching on it. So then let's have a review of the greater trochanteric region. So in the greater trochanter, there are four major facets: anterior facet, lateral facet, posterior facet, and the small one, which is smaller one, is called the superior posterior facet. And then regarding the muscles, there are two muscles attached to the greater trochanter. One is the gluteus minimus, the other is the gluteus medius. So regarding the bursa, the one underneath the gluteus minimus is called the subgluteus minimus bursa. And then the one underneath the gluteus medius is called the subgluteus medius bursa. And then the one underneath the iliotibial tract and on top of the gluteus medius tendon is called the greater trochanteric bursa. So here I place my transducer in the axial plane, and then you can find that this is the anterior facet. So the tendon on top of it is the gluteus minimus. And then the one on top of the lateral facet is the gluteus medius tendon. And on top of it, you are going to find the gluteus maximus is merged with the tensor fasciae lata to become the iliotibial tract. So this is where the subgluteus minimus bursa is located, and this is where the subgluteus medius bursa is located. And the one interposed between the gluteus medius tendon and the iliotibial tract is the greater trochanteric bursa. So for example, in this case, you are going to find what is the pathology. The pathology is over here. The gluteus medius tendon is very swollen. So in this case, actually, what we do is ultrasound guided hydrodissection for this case. Okay, so as you can see, when we encounter a case with snapping over the lateral part, we are going to define them as the external snapping hip. So the reason of external snapping hip is due to the abrupt movement between the iliotibial tract and the underneath gluteus medius. So in this case, of course, we use the 25% dextrose to dilate the space between the gluteus maximus and the gluteus medius tendon. And afterward, we let our needle get into the gluteus medius tendon to do paperin injection technique. So paperin injection technique is very useful for tendons with tendinopathy. So after dextrose injection, you are going to find the tendon become less swollen and the echogenicity was much improved. So another case, this case comes from a supermodel in Taiwan, and she loved jogging. So what happened to her tensor fascial iliotibial tract? As you can see, if you compare with the normal side, the one at the pathological side is significantly thickened. So that's why when we do the ultrasound scanning in the ACL view, we are going to find a focal thickening of the iliotibial tract. So this is the reason why the case has snaking. So likewise, we use the dynamic ultrasound to validate this is the culprit of the snaking here. So what were we gonna do? We use the needle to perform tenotomy to dilate the thickened iliotibial tract, and afterward we find the symptom in the light. So another case with lateral hip pain, and in this case, the pathologist over here, there is a huge hyperechoic point at the insertion of the tensor fascial lata. So if you have X-ray, you are going to find that the patient has a avulsion injury of the anterior superior iliac spine. And then, also brief part. Okay. Okay. So in this case, you are going to find the patient has lateral hip pain, and at the lateral hip, you are going to find the insertion of the gluteus medius. You are going to find a hyperechoic plate over here. This is the reason why the patient has pain. So what are we going to diagnose this case? We are going to diagnose the case as gluteus medius avulsion injury. So another thing is at the greater trochanteric region, there are many tendons and muscles can cause pathology or cause pain. Another one is the gluteus minimus. Gluteus minimus emerges from the posterior iliac wall, and then it's going to insert on the anterior facet. So this is the normal one, but if you compare with the pathological one, you are going to find this area, see, it's severely swollen. So use comparative ultrasound, you can diagnose the patients with gluteus minimus tendinopathy. So if you encounter patients greater trochanteric pain, the most common injection technique is the greater trochanteric bursa injection. So we are going to inject into the fascial plane between the iliotibial tract and the gluteus medius tendon. So once you push the injector, you can see the dilatation of the bursa space. So very importantly, you have to know that the greater trochanter is located posterior to the middle axillary line. So once you compare the greater trochanter, you are going to know this represents the anterior facet, this represents the lateral facet, this represents the posterior facet. So what are the muscles over this region? At the most anterior part, you are going to find this is the tensor fascial lata. So tensor fascial lata is going to give of fascial extension, and the fascial extension is going to merge with the gluteus maximus. So on top of it, you are going to see this big muscle represent the gluteus medius. Gluteus medius is going to insert on the lateral facet, and then the smaller one, which located deeper to the gluteus medius, is the gluteus minimus. So lastly, let's talk about the posterior hip. I think at the posterior hip, the most prominent one is the piriformis. But if you want to scan the piriformis, first we place our transducer in the axial plane over the posterior iliac wing, and then we can see gluteus maximus and the gluteus medius. But if you move your transducer distally, you are going to see a muscle emerge from the greater sciatic nerve. This represents the piriformis. And you have to remember the orientation of the piriformis is not in the horizontal plane. The lateral end of the piriformis need to point to the trochanteric fossa. This is the trochanteric fossa over here. So this is the whole axis of the piriformis. So before we start the injection, it's very important to know that between piriformis and the gluteus maximus, you usually see a hypoechoic space. This hypoechoic space is not effusion, it's actually some peptide. So because many years ago in Taiwan, we have some doctors who claim this is effusion. So one day I was curious whether this is effusion or peptide. So that's why I asked my friends in Czech Republic to do a collaborative study. And then when they dissected, they found lots of fat over here, and the under ultrasound image, those fat would look quite similar to the effusion, but in reality, this is a fat instead of effusion. So another thing is nowadays, when you encounter patients who are fed with high resolution ultrasound, you are capable of diagnosing it. For example, in this case, you are going to find the tip piriformis muscle thickness is much smaller than that over the normal side. So regarding the posterior hip, there are several muscles like the superior geminis, which is on top of the ischial spine, and the obturator internus, which has a significant intramuscular tendon inside, and then the inferior geminis is on top of the posterior hip joints, and then regarding the quadratus femoris, you are going to find underneath the quadratus femoris, you are going to find another muscle, which is the obturator ischius. So this is how we perform the piriformis injection. So piriformis, the pathology can happen in the tendon and in the muscle portion. So you can, before you do the piriformis injection, you have to know the location of the sciatic nerve, because it's possible to injure the sciatic nerve. So once you get into the fascial space, you can push the injectate to let the injectate spread it on top of the piriformis. So another pathology that is also common is when patient complain pain during sitting, and it usually results from the problem of the ischial tuberosity. So it's common for patients with ischial tuberosity, calcification, and then the calcification is going to irritate the tendon on its top. So we can use short axis to see it, and then we can also use long axis to see its calcification. So if you want to perform the ultrasound guided injection, it's quite easy. You place your transducer in the axial plane and insert your needle from lateral to medial, and then you can succeed in the injection. So finally, if you want to look for detail of this topic, you are welcome to reach our article published years ago. And then, thank you very much.